What the flip's up with confusing medical debt? That's up next on What the Flip. Hello, welcome back. I'm Vic Vogel, your host. I can tell you in 2 words what the flip is up with medical debt. Higher cost. In fact, medical costs are increasing each year. But you have to know this, not all doctors are getting filthy rich. And certainly no medical personnel are getting rich. So why are medical costs out of control in this country, but no other industrialized societies? I've been reading the most interesting book called In Medical Debt by Jerry Ashton, Robert Goff, and Craig Antico. And I'm going to read you a few quotes from the book that should get your brain burning to find out more about medical debt. And I'll give you a link to the book in the video description. The following information comes directly from this book and clearly explains why medical cost is increasing and the suffering that isn't causing. So let's get right to it. All right, let me take you just a few minutes and read some sections out of this chapter. It's chapter 6. It's written by Robert Goff. Title of the chapter is Margin Over Mission, Head versus Heart. You'll understand a little bit of this as we get into that. Robert says the healthcare industry is a huge part of the American economy. Along with spending on services, the healthcare industry is the largest source of employment in the nation. All the trillions spent on healthcare are spread across numerous enterprises, yet it's really concentrated into 2 components, physicians and hospitals. The American Medical Association reports these 2 represent of all healthcare spending. Now, while he also says, while we think of them as linked, hospitals and physicians are different and separate economic units. How each is compensated has determined how they have evolved, and how they evolved greatly impacts healthcare costs. All of these costs outstripping the ability of patients to pay is what creates medical debt. That's an interesting scenario, isn't it? We'll see. Dig into this a little bit in depth here. Robert goes on further to say, consolidating economic power is increasing healthcare cost. The structure of healthcare delivery is a vestige of the 19th and 20th century concepts and limits. If care required more than a physician, the hospital played a critical role as a hub of sophisticated services and technologies such as surgical services, radiology, and laboratory. Before immunizations, hospitals also protected communities from communicable diseases. Hospitals continue this local role while the world around them changed. Isolated communities were linked by roads and bridges. Populations shifted. Advances in medical science and technology reduced the need for hospitals' core service, inpatient beds. Hospitals survived by adapting between 1975 and 2015. About 1,500 hospitals closed their doors. Eliminating beds in hospitals did not slow spending. Statista reported hospital expenditures rose from $27 billion in 1980 to $1.2 trillion by 2018. Robert continues on, the hospital evolved from a community charity with a mission of service into a business enterprise. To meet the public benefit mission they had, hospitals were licensed to guarantee competence. Licenses let hospitals become monopolies or oligarchies in their service areas. Hospitals used business techniques to control how the healthcare dollar was spent. Their license let local hospitals dominate inpatient services and then control outpatient and physician services. Hospitals became profit centers. I always suspected capitalism wasn't great for the healthcare industry, but this really brings it home. So Robert continues on and says, hospitals next merged with other hospitals and other sections of care delivery, like urgent care and ambulatory surgery. A system was created that not only dominates delivery of care, but exploits it economically. Hospitals grew at the expense of communities that the hospital founders had pledged to serve as a mission. Hospitals are compensated for services provided. The more the services, the greater the revenue. Hospitals are paid formula-based rates for Medicare and Medicaid. Hospitals are paid more for both Medicare and Medicaid services than independent providers are paid. Commercial insurance plans negotiate hospital service payments. A monopoly of oligarchy hospital system negotiates from a position of strength in the local geography. Pay the demanded rates or don't do business with the local healthcare system. Press releases for nearly every merger promise cost savings. After a merger, Forbes reported prices rose upward to 44%. Not every hospital dominates the local market. Hospitals with favorable Medicare rates, Medicaid rates are actually rarely profitable. Plus a solid volume of commercially insured patients can expand their profit margins by negotiating increased payments from insurance companies. Higher insurance payments get passed on to patients, of course, as higher insurance premiums. So there, you're now understanding what's going on. We've infused capitalism into the healthcare system, and now we've moved off of a basic mission of taking care of people to earning profits by exploiting people. And it's pretty evident here with this information. Now, these hospitals have gained control over the healthcare system, these large oligarchies and conglomerates of hospitals, and some of the people who take care of us, who actually take care of us, are the ones that suffer from this. And I just want to take a small section out of this for this particular session, and I'll produce some more of this for you in upcoming sessions. But right now, I want to talk about physicians. And Robert says in this chapter, hospital systems grow by adding physicians as employees. How about, or you say how? And it's about 80% of U.S. healthcare spending results from decisions made by physicians. 80%. I'll read that again. About 80% of U.S. healthcare spending results from decisions made by physicians. Influence or control that care decision, and you control a significant amount of the revenue. Employed physicians yield a regular flow of patients, referred to ancillary services owned by the system. Systems-owned services are paid more than independently owned services. So boosting patient volume assures that the system's overall cost for healthcare will rise. So they bring employees on as doctors, and then doctors refer them to the hospital, but they don't just refer them to the hospital for admission, they also refer them for things like test and lab work and a bunch of other things, but they want the hospital to do this lab work by the services the hospital owns. The hospital inflates those charges over another service that might be out there in the community operating independently. So there's another rationale for driving up the cost, and another one that has to do with capitalism. Continuing, Laboratory Economics reported that a United Healthcare in-network hospital lab in New York charged 23 times more than did a local lab, LabCorp, for the same test, $384 versus $16.25, folks. Medical Economics has reported that Medicare paid $188 to an independent physician for a level 2 EKG without contrast. The same EKG in a hospital outpatient setting cost 140% more, or $452.89, when charged by the employed physician using the hospital for the service. Costs from hospital-employed physicians are a physical drain on Medicare. Modern Healthcare magazine in November 2017 ran an analysis of U.S. costs for 4 procedures at hospital outpatient services and independent locations. Employed physicians generated 27% more Medicare costs, $3.1 billion, than did the independent physicians. Employed physicians were 7 times more likely to provide services in a more costly hospital outpatient setting. An Empire Blue Cross executive said the cost of care provided by an employed physician is 20 to 40% higher than the cost of the same care by a physician in an independent practice. Hospitals' employment of physicians is increasing dramatically. Between July 2015 and July 26, hospitals acquired 5,000 physician practices, reported Healthcare Dive. It's a research company. Separately, Fierce Healthcare reported that hospital-owned practices increased 100% in the 4 years ending 2016. Nearly 38% of all physicians' practice are now hospital-owned. So if you try to have an independent business as a physician in a small community or even a metropolitan community, and you're not employed by that hospital, you're really struggling against a major hospital organization that's literally controlling your market area. If you don't refer them, if you don't become employed by them, the referrals, although they can't stop them, they're probably much more difficult to do. It's pretty amazing, isn't it? But think about why we're paying so much more, the inefficiencies, the ineffectiveness systems, all because we have basically a capitalistic organization now that had a mission to take care of people. It was a socialistic mission in the initial development of hospitals. Now it's become a capitalistic system, swung 180 degrees, and you see the difference. You see the difference in cost, and you also see the difference in patient care and quality. In this chapter, Robert says, an online video, The Vanishing Oath, narrated by Ryan Flesher, MD, gives us a clear sense of the financial realities of the average physician, independent physician. The average compensation for independent physicians in the USA is $146,000. 3 times the national average for household income. However, when you factor in overhead and working hours, physicians' take-home pay averages less than $28 an hour. It's above minimum wage of $15 an hour, but not by much. And most minimum wage now, of course, isn't $15, but it's getting there. The average charge from more than 200 million visits paid by Medicare in 2012 was just $57, less than a plumber charges to fix a broken toilet. Another factor in physicians' life is the burden of debt from a medical education program. Student debt relief estimates medical students graduating in 2018 had $190,000 in debt. This affects where they choose to practice, whether they're independent or employed. In communities where a population is economically challenged, private practice physicians are in short supply. You wonder why. Practice costs cannot be met through a high volume of low-paying Medicaid patients, not without the quality of care suffering. Therefore, physicians tend to congregate in high-income suburbs or upscale urban neighborhoods. Where and how physicians practice medicine becomes more about lifestyle and economics than meeting a community of needs. Ladies and gentlemen, this isn't about doctors. This isn't about the people who take care of us. This is about conglomerates and business owners at the top of organizations moving the healthcare system from one of being concerned in providing high-quality healthcare for anybody who needs it. And trust me, you don't have a choice as to whether you need it or not, to being a profit center driven by money and greed. It's pretty clear why we're in trouble and why we need to do something about this. It doesn't cut the mustard to say we're going to go with the status quo or improve gradually on what we're doing. All through that period of time, the cost is going to far outstrip what we do by simply taking gradual steps. We need a major, radical change in this whole system. We need to put everybody on Medicare for all, put all doctors and hospitals on that system, standardize the costs, standardize the payments, and pay doctors realistically what they should have to earn a decent living, and then help them with their college education so that we can have people in rural communities and helping in urban areas. There's just this just makes total sense. If we want to change this, we have to take a radical approach. So think about that when you're deciding who to vote for. Who has the radical approach, and who's preaching, oh, let's just stay with the status quo? The status quo is going to kill us. And I mean that literally. This is What the Flip. We're going to provide you more on this area of medical debt and health care in the future, because it's important to you. It's important to the people that you're going to want to be taken care of in the future, your children and grandchildren. I'm Vic Vogel. Until next time, I'll see you then. I suggest you vote for that radical healthcare change.
You can like my Facebook page, What the Flip, and follow me, and stay tuned for more broadcasts of this podcast, What the Flip. Until then, have a great day.